good to see you not in the
Awesome.
Yeah.
All right. Dr. Beckett on the chronic couch. He performed an L4, L5 discectomy once in September of 2022. The second one was in 2024. That second one was supposed to be a disc replacement, but you wimped out the night before.
Yeah.
Just kidding. We'll get to that. But before we dive in, you've kept it real with me this entire time, and that's something that's kind of made the journey easier. So today we're going to keep it real. We're going to get right in there, grab our scalpel, help some people out who are struggling out there with back pain or chronic pain, and then we'll tie her up and keep her moving.
Great.
So you are a board certified neurosurgeon. You're at UCLA, now you're at DISC, and I snagged this straight from your website. You specialize in the surgical treatment of spinal disorders such as stenosis, disc herniations, spondylolisthesis, spinal deformity, and tumors, with extensive training in both minimally invasive and complex spinal surgery. Is that about right?
Sounds pretty good, man. Sounds like I wrote it almost.
So, first off, what are your thoughts when one of your patients, like myself, has turned their back pain, their chronic pain experience, even collaborating with a fellow chronic dude, and has turned such profound experience into a passion project like the chronic couch?
Oh man, it's awesome. I mean, I think that, I think it's a great example. The truth is, right, back pain, neck pain is the number one cause of disability worldwide. Number one. Years lived. 80% of the population on any given year complains of some episode of back pain, neck pain. It's everywhere. It's something we all live with, right? And pain impacts us differently in different ways, and there's more severe and less severe, but it's something that sits on all of us, one way or the other. And flushing it out, talking about it, getting through it. I mean, as you know as well as anybody, the mental aspect of pain is, I'm not going to say it's 90% of the battle, but it's a significant portion of the battle. And, you can discount it and you can say, oh, it's not that bad, or you can be too positive about things, be like, oh, I fought through it, I got better. But the truth of the matter is it's always there. We live with it. And so the best we can flush it out, talk about it together, and really work through it that way in a healthy way, I think it's awesome. I think it's awesome.
Yeah. So like I said, I first saw you in 2022, and I believe your teammate Brian, you were not at UCLA, right?
I wasn't when he treated you, but I worked with him after that.
After that,
Yeah.
Okay. And I was trying to think the other day how I found you, and I can't remember because I was so messed up.
I remember meeting you, man.
I remember that with my mom.
Yeah, your mom.
Yeah.
Yeah, you couldn't get off the exam table. I remember you laying there. I walked into that room. I remember. Yeah. You looked bad. You don't look bad now. You look good, but man, I remember, because it's not all the time that, especially when I was at UCLA, I was treating a lot of tumors and a lot of, really bad types of pathology. And it's not every day that you walk in the room, you see a pretty healthy looking young dude who is like in extreme pain. And I can tell you weren't faking. You weren't being a baby about it or anything like that. You just couldn't move. And I was like, wow, this is. I mean, I was impressed by how much pain you were in.
Yeah, and I think that's something that I've learned and Chris is going to touch on acceptance. That's been like a huge overarching theme for people that tune into the chronic couch or people that come on the chronic couch is acceptance, which I just got to that place maybe 4 months ago. And that actually helps you heal, acceptance being like you have to bring a freaking back pillow wherever you go, but it is what it is. So I saw you again in 2024. That's when Brian came along, and I just felt like it was absolute hell. I couldn't get dressed. I had to keep food in my bedroom because I just couldn't get to the kitchen. I know one thing that you really hone in on with your study and your practice is modern spinal care. Can you just quickly tell us the main differences that distinguish between traditional versus modern spinal care?
Yeah, I think it's a great question, and we could talk for an hour about that alone. I think the foundation, how we should start this, is the acceptance that we're not doing spine care that well. As a kind of a Western spine surgery, pain management field, and I think we just need to acknowledge that. There are some things in medicine I think we do extremely well. Most successful surgery that exists is hip replacement surgery, right? Hip replacement surgery is over 90% success rate. People are happy. Grandma breaks her hip and then she walks again, and it's fantastic, right? But we didn't start there, right? If you rewind the clock, first hip replacement was made in 1958. And before that, you break your hip, you had your leg fused to your pelvis, right? Fusion, that's a word that we're familiar with, right? When we're talking about spine. So in 1950, you broke your hip or you had bad hip arthritis, you were talking about getting your leg fused to your pelvis. In 1958, they had the first hip replacements that came out, and they were not great. It took decades of evolution and understanding and trial and error and treatment to make that where it is now. But I think if we take even one bigger step back from that and say, okay, we're treating, in 99% of the time, when we're talking about spine stuff, we're talking about pain. We're talking about what you experience. We're talking about the pain that we all live with. Spine pain, like we're talking about earlier, it's the number one cause of disability worldwide. Number one cause. It's not diabetes, not heart disease. It's actually spine pain. If you look at how it impacts people for years lived, right? And 80% of the population on any given year is experiencing some episode of spinal pain that's notable, right? And so it's everywhere. And so the first thing we need to do when we talk about modern spinal care is understand that in tackling this ubiquitous problem, we have to start at the ground level, right? The ground level of modern spine care is to understand that our modern existence is not great for our spine. We are sedentary. We're overweight as a population. Our diets are bad. Our mental health is bad. Mental health leads to increased perception of pain. Pain leads to worsened mental health, right? So we have this milieu, we have this foundation that's just bad for back pain. And then we're applying surgical techniques that are imperfect. They're fusions, right? They're antiquated. We haven't even broken into the next generation yet. And we're starting to do that. There's some great stuff happening with disc replacements. It's something I'm extremely passionate about. I love them. I think they're amazing. But there's a lot of resistance to that kind of technology. And there's a lot of resistance to change and resistance to how we treat these chronic problems in our medical system. And so I think modern spinal care focus is a focus on, again, it's an acknowledgement that we're doing it imperfectly, and by acknowledging that, we can ask ourselves how we can do it better. Two, it's an understanding that it is a chronic, ubiquitous type problem for most people, and so we need to start on the ground up and be really thorough and accepting of other ways to get people out of pain that aren't opiates and surgery, right? Which is what we did and which is bad, obviously. And three, it's just constantly pursuing, just trying to be better, not only as a field, but as a medical provider itself. So I think that's the view of modern spine surgery and modern spinal treatment, as opposed to previously where, a lot of my older mentors, patients would come in, you look at the MRI and they'll say, oh, I know what to do here. I don't know what to do based on an MRI. I don't treat an MRI. I treat the person across from me, right? Because an MRI on you is not the same as an MRI on him or an MRI on me. The pain that you feel is what's important. And understanding the pain you feel and how that impacts you and where that comes from, and if there is a structural foundation that makes sense, that's way more important than just looking at a picture and saying, oh, do we fuse this one? Do we decompress that one? And that's what we used to do, and still many people do, but that's wrong.
And you mentioned fusion, and going into this experience before I even knew anything about back-related symptoms, I always heard, do not fuse, do not fuse. And that was one of the things that I liked about how you decided to treat me was, we're not going to fuse. I think that was like, I remember you saying you have 3 options. And then I think the third one was a fusion, which you said you wouldn't do.
Yeah.
If you want to pull up my scans, and I'm going to talk about my symptoms. And then maybe Brian, if I'm missing symptoms that people experience with back pain, if you could just chime in. And then Dr. Beckett is going to have my scans, and he might be able to explain why I had these symptoms, such as sneezing and coughing were horrible. That was number one, the worst thing. I was like, fuck, I'm about to sneeze. But I learned, grab a pillow, hug the pillow when that's happening. That seems to help a little bit. Tingling, burning, stabbing, spasms, sharpness. I'm still having a little bit of neck issues. And I think that's just from, posture, pain in my fingers, breathing in chest pain, disassociation, losing the concept of time. This is when I was in the thick of things, and I think Chris could relate too, when he was in the thick of his chronic pain. The mental game is at an all-time low. Am I missing any symptoms? Did I hit them all?
No, that sounds right. Consistent with what you were experiencing when we saw you.
Yeah.
The pain going down the leg, worsened when you're sneezing. You did have a disc reherniation. When there's increased pressure down there, it can exacerbate your symptoms, as you can probably explain as well. But I know you were going through a lot of tough times with that, and I'm glad you're doing a lot better. But that sounds consistent with what your pathology was.
And with most of your patients too, right?
Yeah, it's pain impacts everybody differently. I will say that sometimes fusion is needed for certain pathologies, right? It's just we over-apply it, right? It's, when all you have is a hammer, everything looks like a nail, right? And if that's the technology that's being applied in spine surgery, everything's not a nail, right? Absolutely not. And so a lot of times back symptoms or neck symptoms, I kind of boil it down into 3 categories. The first category is neural compression type problems. And so the spine has 2 roles, right? Role 1 is, we'll flip it actually. We'll boil it down, we'll say biomechanical issue first. Role 1 of the spine is the connection, is your center core. It's what connects your legs and your pelvis to your upper torso. If you do a cross section of your belly, the only bony structure there is your stack of bricks, your bone, is your spine. That's all it is, right? And that, we ask so much of that. We ask that to connect our upper body to our lower body, to accommodate all of our flexibility, all of our minor motions. It's how we sit in these chairs, it's how we stand, right? And these bones are not very big. They're really only about 1.5 inches to 2 inches in diameter. So you think about that, and you think about the discs between them. And you think about the job that we ask that spine to do, day in, day out, under gravity, in all of our positions, in all of our repetitive motions, in our athletic motions, what we do. And what we ask of it, we ask a lot. So its first job is to that. And you can have issues with that, right? That can cause problems with just arthritic pain, just good old-fashioned bone-on-bone type rubbing pain like you would get in a knee or a hip or a shoulder or anything like that. The second thing you get right is nerve pain. The second job of the spine is to be the conduit for the neural elements that travel from our brain to our arms, legs, to our lower half, our upper half. All the nerves, except the ones going to our face, travel through our spine from our brain. And you can have problems in those passageways, both from the arthritic buildup, from disc bulges, from honestly all kinds of things. But nerve symptoms, as you know now, are terrible, right? Nerve symptoms, because it's almost like the pain's not real. It's like arthritic pain, we kind of understand, we're creaky, a little achy in the morning, you shake it out. Nerve pain is like just a live wire, right?
Yeah.
The third thing that all of this does, right, is the third role of the spine, and I think is really kind of a fundamental, just core axis of our being. And I think that and this is almost like more of a philosophical way that I think of it, I think the spine is the center core. It's the center part of your entire being, and it's what unifies your mind and your body. And when you have errors in that structural component to your body, to that pathway, that center of you can have errors with just your being. You can feel off. You can feel just not yourself. You can lose perception of time. You can feel stuck in things. You get depressed. You just don't feel like your machine is connected to yourself. And I think that these things together, you know, people get symptoms from all of these things related to their spine. And the constellation looks different for a person, but that's the unifying thing. And that's, so those things you experienced, I hear those things.
So both surgeries that I had brought immediate relief to, let's say, the leg pain, that leg stabbing. But I still have, and this is my biggest complaint, and I know you said it would take time. And again, I don't want people to think that, you know, the lingering stuff has to do with, it could have to do with the surgeon, but
Yeah, do a bad job.
but in this case, it's more about the recovery. And if I had, you know, more money to spend each month, I would be doing things like ice baths, like religiously, massages. So going back to nerve pain, and you're looking at my scan, can you tell me and others why I might still be experiencing nerve pain, and then why it was so intensified pre-op?
Yeah, great question. So spine's complicated, but in the low back, easiest way to think about nerve pain, how I think about it and how I always kind of conceptualize it in my head, the pathways that the nerves run is like the highway. It's like the 405. You're gonna have your center lanes of traffic, you're gonna have exit lanes, they're gonna be symmetric, one on each side, and you're gonna have exit ramps. And they're gonna be at set intervals. And that's gonna be each level in your spine, just like the highway, that's what you're gonna be. And so when you're a car or lane of traffic, or when you're a nerve and you need to get off on a certain exit ramp, and that's where you're going, what are you going to do? You're going to move from those center lanes of traffic, you're going to move to the exit lane first, and then you're going to take the ramp out. When you're in the center lanes of traffic, you have options as a car on the highway. You can move, you know, you can change lanes if there's somebody slowing down, if there's a blockage, you can move and you have some flexibility. When you have to get off on that exit ramp, and that's the exit ramp you have to get off on, and that's how our nerves work, they get off where they get off, you have to be in that exit lane, and then you have to be in that exit ramp. And if there's a blockage there or a traffic jam there, you're not going anywhere, and you're going to be really, on our highway analogy, you're going to have tons of road rage. You're going to be extremely upset. Your nerve is going to be very irritated because it's getting pressed on, it can't move anywhere, right? And so when we think about your spine, I don't know if you guys can see it, but for example, you know, if we're just talking about nerve pathways, so on the left side is a side view, on the right side is what I call kind of the bread slice view. It's that yellow line, it's cut right through it. And what we're really looking at here, we can see my mouse, that's that highway. These are the lanes of traffic and all the nerves in that spinal canal. Now, just like the highway, the exit lane is going to be the far edge of that highway. And the exit ramp is when they turn off and they shoot out the sides. Now as we go down, we see this part, this is nice and circular, everything looks wide open, all the nerves are open. As we come down, and you can actually see these nerves migrating out. Look, these are the one on this left side, it's reversed. This is the left side, this is the right side. Those are the nerves moving to the exit lanes, and they're gonna exit out of the highway. See how they fly over to the sides? They're all happy. Everything here is pretty happy, and then, boom. Here, we have this black structure, which is a disc bulge or a disc herniation. And you can see it's blocking the exit lane on that right side. The left side remains open. Left side looks pretty good. This is going to be pressing on that lumbar 5 nerve root, because that's the nerve that's going to be taking that exit ramp. And that's the nerve that runs through your buttock, the outside of your leg, down your leg, through your shin, through your foot. Right? That's the pain you're having. And that's exactly why you're having that pain at that time. Now, nerves are finicky beasts, unfortunately. When they get upset, they can get upset again really easy. So even if you're not having a disc bulge anymore, because of the severity of symptoms that you were having from that disc bulge initially, you can be susceptible to recurrent nerve irritations just from day-to-day normal stuff. Just like normal traffic on the highway, right? There's no blockage, but a little bit of stop and go traffic, maybe you get road rage easy. Your nerve gets road rage easy, right? And that connects here, mentally, right? is good evidence that shows that when we are more depressed, when our mental health is not as good, then our nerves that feel pain tend to be more susceptible to registering that pain to us. And it's probably how we process it up here. We're probably all the time sending these little aches and pains up to our head, but it's like no big deal.
Right.
But if we're not right up here, we feel it way more. And our pain is worse, then you feel worse. It's a terrible cycle. For you, the other thing that's the big player for you is, as a former gymnast, as an athlete, we got football, we got a gymnast, and then the only thing we don't have is a weightlifter. I don't think you're a weightlifter, right? Those are the big
Basketball.
three.
Basketball.
Oh, my bad. My bad. Oh,
You're like a football player, though.
He's just a big guy, man. I don't know.
Dancers have bad backs too.
Yeah, but the big three,
Yeah.
the big three are football, gymnastics, and weightlifting, heavy weightlifting. Those are the big three for back injuries, right? That's the big three for back injuries. And so here you are, a high level gymnast, and I look at you and you have 3 bad discs. And what I mean by that is this level here is a good looking disc. It's light colored. It has the lightness is water content. So a healthy disc, a lot of analogies, as you probably guess, and we've already started a couple of them.
We got the jelly donut.
Yeah,
they know about
jelly
the
donut. Yeah, I'm leaving that one on the side. I don't like
Yeah.
jelly donut. You know what I like? I like grape.
Great.
A healthy disc is like a grape. Now it has a really strong rind to it, but I want you to think of it cross section where the inside is this very fluid filled, squishy, bouncy, nice grape, right? That's a good disc, right? The rind is a little more dense than what you would think, or the outside, the encasement is a little more dense than what you think a grape would be like, but it's kind of like that. Think about if your grape gets little rips in it over time. What happens? It starts getting squished, it's a little squishy, and then that fluid goes away, it dries, and then it squishes more and it dries, squishes more and it dries. Then what do you have? A raisin. That's what a degenerated disc ends up being, a raisin. Raisins don't cushion very well. And so when you go from a healthy, well-hydrated disc with low acid content that doesn't have a lot of tears and rips in it, has not been used very much, and over time of wear and tear, and there's a lot of other factors that we found that increase disc degeneration, like blood supply, acid content, smoking status, all kinds of things. Dries out, rips with time, loses its hydration, becomes more raisin-like. Raisins don't cushion bones. Raisins also don't space the bones. And so remember those exit ramps. So nerves get out between the bones. As you lose the height of the disc, those exit ramps get smaller and you can get nerve irritation from those. And those are very difficult. Those are the foramen and those are the exit ramps. Those are hard things to decompress. That's typically when I recommend things like, you can do it, but that's typically when people traditionally would get fusions and things like that.
Okay.
I just want to bring this up for the camera in case people can't see it. Could you, this should be right in camera, could you just show us, because Eric and I have been talking about this. We talked about this all season 1, but could you show people where Eric's issue was?
Oh yeah, absolutely. Right. So yeah, by convention, we count from the bottom. So this is the sacrum, this is sacral 1. Then you count up lumbar area. So lumbar 5, lumbar 4, lumbar 3, lumbar 2, lumbar 1, and then you're in your thoracic. So his main issue with your disc herniation was at lumbar 4-5, which is the disc space. And we always tend to describe the issues as being the space between the bones because the issues are typically with the discs. So we say lumbar 4-5.
Which is the most common, right?
The most common.
L4, L5.
Yeah. It's the highest amount of biomechanical shear stress on most people's backs. Now, everybody's back's a little different. That's the thing. Everybody's got different curvatures. Everybody's got different load sharing and load activity. But if you take averages, 4-5 is the most common.
Okay. So, what is your philosophy? Surgery or non-surgery? Get the surgery, don't do surgery.
That's a really good question. I have just a couple times when I will recommend surgery straight out the gate. And those times are when there's obvious nerve dysfunction from the beginning. And I mean like weakness. I mean like your foot doesn't work. Your foot won't move. There are extremes. Everybody who's in medicine learns about, cauda equina syndrome and incontinence and things like that. And that's even the super farther end extreme. But really, generally speaking, the only time, and there might be some others that I'm not thinking of, but the only time I'm really first out the gate say, I think you should have surgery, is if the nerve is being squished or compressed so badly already that your muscle, the motor doesn't fire, the muscle doesn't fire. Or if you have a spinal cord compression that is so significant that you can become paralyzed if this continues. And those are obvious times. Every other time, frankly, we tend to try conservative measures first.
PT.
I mean, it ranges, right? We can say, I think that there's both. I think there's every page. So PT, I think, is great, especially, if the person is a little bit deconditioned or could use a little help there. Chiropractic can be useful, but it's a little bit of a mixed bag. And I'm sure some people will be upset about that, but that's kind of how I feel about it.
Well, I'm with you on that too. So.
That's kind of how I feel about it. Yeah. I think that low-lying fruit pain medications are reasonable. NSAIDs, Tylenol, like Salon Paws, Tiger Balms, just massages, just easy stuff that has a low buy-in, so to say. Like try them, because if we go back to that initial statistic, right? If 80% of people are experiencing pain in their back at some time during the year, what that really means, because not 80% of people are getting surgery, right? So what that really means is most people's back pain gets better. And it gets better with time and a little bit of help. And the help is PT, easy medications, massage, and then there are adjuncts, right? There's acupuncture, there's all the things. And if all of these things, as far as I'm concerned, if it's not risky, it's not going to break the bank for you, is a reasonable thing, try it.
Yeah.
Try it,
yeah.
And then there's a whole other element. Chronic pain is a difficult thing, right? And there's a lot of pains out there that people experience that we don't have great structural. When we look at the spinal imaging or we look at something and we say, I don't know why you're hurting, really. And it's always good to get multiple opinions, if somebody tells you that, it's reasonable to get another opinion just to be sure that no one's missing anything. But there are those times when people have pains that we don't have structural causation in the back. And then it's a good time to focus on our perceptions of pain. And so some things to manage pain there involve mental health care and things like that. And it can be a major component of how the pain impacts our life. Because I think that, to go back to kind of something we've harped on before, I think all of us experience some element of pain every day. Yeah. There's something, right? And when my child stubs his toe, he cries because he's not good at emotionally regulating that pain. We can, that bit. But I think that's an analogy for all of our pains. And, there's a limit to it, but there's a lot about how we can emotionally regulate and tolerate in our overall mental health, and that allows us to stand or live with or function with the pains that we experience.
So I re-herniated, and I think I know why I re-herniated. It is because my degenerative disc disease was so gnarly, so bad. Are there statistics that back up people re-herniating after a discectomy?
Yeah, I mean, there is.
I also didn't recover as well as I should have. So I think that played into it, but
it's hard. It's hard. So there's the immediate risk of reherniation after a discectomy. So if you need to have a microdiscectomy because of all the things we've kind of talked about, there's about a 10% chance that you reherniate within the first few weeks after a surgery. And that's predominantly because the majority of when a microdiscectomy is performed, whether it's done endoscopically or traditionally or whatever, what happens is you pluck out the bit that's come out, but in a lot of those people, the little exit, the rip in the jelly donut is still there.
Yeah.
And so we compress our discs massively on a day-to-day. So like we're sitting right here in these chairs, and the change in pressure in my L4 or 5 disc right now when I'm sitting versus when I stand, and this has been studied, there's about a 400% increase in the intradiscal pressure when I'm sitting right now versus when I stand. And it's how our spine loads. When we sit, our kind of butt tucks under and we pogo stick like directly onto the discs. And when we stand, we load our facet joints and we use our musculature more. And so the more bad posture we do to sit and all these things, you know. But the evidence as far as an individual, once they've had one disc herniation, then having more disc herniations, it's a mixed bag. It really depends on the level and the person. I think for you, the writing was on the wall based on it being your lumbar 4-5 level and how diseased yours was already. The hope is typically that you get the one clear and you don't need another. Unfortunately, you know, that wasn't your case.
And maybe walking 20,000 steps like 6 weeks post-op wasn't the smartest thing, but
I still don't understand how you do that much, man. I mean, that 20,000.
I'm there right now. I'm there right now.
It's amazing.
Hey, more power to them.